बैठे Good afternoon. You people can come on this side if you feel. I think that would be more comfortable. Okay. I think last time we discussed the diagnosis of tuberculosis, and today we are going to discuss the treatment aspects of tuberculosis. As I talked earlier, that tuberculosis is the most ancient and widespread disease all over the world, in fact. And incidentally, yesterday was the World Tuberculosis Day. Every year, the world kind of remembers tuberculosis as an important issue on 24th March. 24th March is the day when the mycobacterium was first discovered, you see. This was in 1882. So almost 40 years ago, and it was Robert Koch who was the discoverer. Before that, of course, nobody knew that it is a infective disease. So um, from that day onwards, of course, the control of tuberculosis became relatively easy. At least this people started imagining that the tuberculosis can also be eradicated, you see. And that's why the WHO theme for this year's tuberculosis, yes, we can end TB. You see that earlier nobody imagined it that it can be eliminated. It was only controlled tuberculosis. You see, there is a difference between control and elimination. You see. So now, and the world has fixed, in fact, 2030 as the elimination target, you see. India, of course, had gone ahead with the fixing it before that, you see, 5 years before the 2030s. So the Prime Minister Modi in particular took this initiative that we will eliminate tuberculosis by 2025, you say. There are many kind of advances which have happened. We have gone through some, that there are methods of diagnosis have improved tremendously. Earlier, we used to rely on the clinical criteria and radiology. We have also improved the drugs and combinations. And then there are other things, you see, like adjuvants, vaccines, and other preventive strategies, you see. Just 2-3 slides on the revision of diagnosis. We talked that it is important is microbiological diagnosis. That is what is most important, you see. So the smear positivity for acid-fast bacilli once or more, that is the most definitive diagnosis. And some people say it is not only smear, but culture should be positive. But culture is not routinely feasible. So most of the time we rely on smear. Then there are immunological and molecular methods. Gene expert is the most commonly employed. Of course, the other are relatively less reliable, the histological diagnosis, the cytological kind of lymphocytic effusions for that matter, or other the granulomatous kind of findings, you see. Empirical is just kind of clinical. People come with weight loss, fatigue, and so on. So those methods are sometimes used in clinical patients, you see. Some of you might remember this slide that so these diagnoses, of course, can be made as suggestive when it is clinical or epidemiological. Presumptive is the second level of diagnosis when the radiological criteria are available, histopathological criteria or other markers, and then therapeutic response sometime. But the definitive is mycobacterial demonstration, you see. Either the mycobacteria, or nowadays they also rely on the DNA of mycobacteria, because that is almost same as the mycobacteria. Gene expert, of course, is a on the site test, rapid test available within hours, cartridge based, so that it can be done even in the villages at the most remote area once the machine is available. So it is a point of care test, relatively costly, but still very helpful, you see. What are the important issues in treatment? Treatment of tuberculosis always uh, depends on whether it is a new case, relapse case, or a kind of drug sensitive, kind of drug resistant case. You see, we'll come to, because that's a big problem nowadays. Then, of course, there are many issues like tuberculosis in the presence of drug toxicity. It's very common because number of drugs which is employed is high, the duration is longer. Sometimes patients are allergic to drugs, other liver toxicity and other side effects may appear. We will also briefly touch upon the issue of latent tuberculosis, because for eradication of tuberculosis, it is very important that tuberculosis is treated before it becomes clinical tuberculosis. There are special issues during pregnancy, in children, infants, in the presence of other comorbidities like diabetes and other thing, HIV patients. Treatment of complications is important. And then I told that drug resistant TBs. And we also, because it is a kind of long therapy, so one has to know how to administer the treatment, what are the goals of treatment, what strategies should one employ, which drugs should be used, because everything should be according to standard protocols for the most effective results. In general, our treatment should be most effective. That is what is the objective. Shortest period of time, effective utilization of available resources, because to control tuberculosis or now to eliminate tuberculosis from a large country like India, a lot of resources are required, you see. Most important factor in failure of treatment has been poor compliance, you see. People leave treatment after a few weeks, sometimes even after days. They start feeling better and they immediately leave it. Or sometimes it is other issues are there. You cannot really go to the place to get treatment. Most of the time it affects relatively more poor kind of society, poor socio-economic groups. So they find it difficult to continue. That's why the program, of course, envisages free treatment, you see. But even then, there are quite important issues. There are many anti-tubercular drugs which are available, from which one has to choose what to give wisely. For example, the oral drugs, these are the most commonly used drugs. The oral are isoniazid, rifampicin, pyrazinamide, and ethambutol. And these are their standard kind of abbreviations all over the world, you see, HRZE. Uh, you should remember it because everywhere they are to be cited like this, you see. Then there are other drugs, new generation rifamycins, rifabutin, rifapentin, mostly used in HIV patients. Injectables are available, kanamycin, amikacin, capreomycin, and earlier streptomycin was most commonly employed, but now, of course, other injectables are more frequently used. Then there are reserve drugs, you see, which are used in either drug resistance or some other situations. We'll discuss them subsequently. There are second line drugs like thiomide, cycloserine, PAS, sorry, it is PAS, terizodone. And then there are nowadays, in certain situations, we are using also very kind of other rare drugs relatively, clofazimine, linezolid, high dose INH, other antibiotics. So these are the drugs which have been found of some use in resistant cases, in relapses, and so on. We'll come to those situations. Fortunately, it is after many years, after decades now. You see, rifampicin was the last drug which came, which was invented. And now we have addition of two important drugs like bedaquiline and pretonamide, you see. These, of course, are not yet available in the market because otherwise they are likely to be misused, as has been as has happened in the past, you see, with other drugs. Side effects are common, especially with first line, second line drugs. But first line drugs, INH, can cause neuropathy, skin reactions, hepatitis, and sometimes drug fever. Rifampicin also can cause hepatitis, flu-like syndrome, sometimes interstitial nephritis. Ethambutol, the most important, is retrobulbar toxicity, optic neuritis, skin rashes. And pyrazinamide commonly causes hyperuricemia, hepatotoxicity, and skin rashes. Streptomycin, ototoxicity, vestibular toxicity, and skin rashes. PAS, of course, is not commonly used now. That is a GI upsets, hypersensitivity. Earlier, these two drugs were also in the first line treatment, you see. Nowadays, of course, we mostly rely on the first four drugs. Second line drugs are toxic as well, in fact, more toxic, but we will not go into those details immediately, you see. Allergic reactions like skin rashes and GI intolerance can occur with almost any drug. You see, that is a common kind of phenomena in pharmacology or clinical practice. The other important issue is the short course chemotherapy, you see. In fact, when we were taught in late 60s, 70s, at that time the treatment prescribed was 2 years, you see. 1 year to 1.5 years to 2 years, 18 months to 24 months. Then they started saying that shorter courses, shorter multiple drugs were, even one year course came, and then 9 months treatment, that was also considered as a short course. But presently we have generally 6 months course, you see. Although there are attempts now to shorten it to 4 months, you see, 4 months regimen. Why shorten the duration? Obviously, because longer treatment is more chances of uh, poor compliance, people omitting the drugs. Then treatment, the shorter course is more convenient, more economical. Patient adherence to treatment is better, you see. And sometimes, uh, not sometimes, in fact, all the time, the results are as good as the 1 year or 1.5 year treatment. In fact, better nowadays. It is certainly better. So these are the three principles of the program, which are most important. One is the short course. Then second is domiciliary therapy, you see. It was, of course, all these studies were done in India and elsewhere as well, in Africa. Uh, Earlier, people used to be admitted for whole 1.5 years to 2 years. Then the Madras Chemotherapy Center, at that time is called Madras Chemotherapy Center, and subsequently it became the National Tuberculosis Center and so on. So they say domiciliary treatment is equally good because there is no extra benefit by bed rest except in very sick patients. There is no increased risk of infection among contacts of patients with domiciliary therapy, you see. Because they say the chances of infecting many people are less once you are diagnosed. And once the diagnosis has been made, patient has already infected several of his colleagues, friends, family members, etc. So, uh, and the moment you diagnose, you will start treatment. So that is then becomes negative, etc. etc. And then, of course, most important was the economic burden is lowered because uh, it is not easy to have so many patients in the hospital. The shortage of beds were there. And then they resorted to DOTS, directly observed therapy, you see, which means it was to ensure the compliance, you see, because then if the doctor, the nurse, or the DOT provider administers the drug in front of the personnel, in front of the health personnel, you see, and then the chances of uh, success are much better. Most importantly is tuberculosis treatment is two-phase chemotherapy. You know that intensive phase and then there is a continuation phase. Intensive phase is initial 2 to 3 months. In fact, for a fresh new case, it is 2 months, and then a relapse, it is 3 months. Continuation phase is 4 to 5 months. So overall, it is 6 months to 8 months for the fresh case uh, and the relapse. You see, intensive phase higher bacillary load because initially the bacillary load is very high, therefore more drugs are used. And these drugs aim at rapid killing. They say, in fact, to kill all the kind of enemies as fast as possible and as large numbers as possible. Rapid killing, infectious period is normally uh, about 10 to 15 days. So with this, it is even reduced to less than that, you see. And continuation phase is for 4 to 5 months because now the bacillary load is less, fewer drugs are used, and they aim to eliminate the residual mycobacteria or the dormant mycobacteria, you see. But the duration in drug-resistant cases is longer, you see. Now, patients are categorized in category 1, 2, and 4. Earlier, there was a category 3 as well, but now the category 1 and category 3 are merged together, you see. So it is for all new patients, what we say is the category 1, all previously treated retreatment cases or defaulters. I mean, there are subtle differences between these things. Previously treated means 5, 10 years ago, patient had got well. So that is retreatment is when it is patient has been only recently treated and then requires he has defaulted, then requires treatment. So there are subtle differences only between these definitions, but this is category 2. And then there are, of course, drug resistance tuberculosis, which initially was said as category 4, but now they classify as drug resistant cases, which can be one drug resistant, multi-drug resistance, or extensive drug resistant tuberculosis. Then treatment schedules for extra-pulmonary tuberculosis and in presence of other comorbidities, especially the HIV use is important. So these are the some of the kind of standard schedules which are used. For new cases, we just talked that 2 months of 4 drugs, and continuation phase is 4 months of, I think it is now, sorry, it is a old slide, and now ethambutol is also continued. This is the earlier category treatment was there. And the previously treated, you give 5 drugs for 2 months, 1 month of 4 drugs, and then 5 months of 3 drugs. I think these are generally, I think once you go into practice or in tuberculosis control program, they have standard packages, you see boxes from which you can always give. Why is the therapy long? One is that there is a disease pathology, the high load, drug penetration is sometimes poor in the organs. Then there is phenotypic resistance of, especially of the persisters, the mycobacterial persisters. There are also categories of non-growing mycobacteria. There's stationary phase. We'll just show you some of these microbiological kind of concepts were used for longer therapies. In fact, that they say that the tubercular lesion is like a Russian matryoshka doll, you see, where there is a doll within a doll, you see. This is a small toy, is a very famous Russian kind of toy. So this is so there are layers of mycobacterial population, and the different drugs penetrate at different times the inner layers, you see. So to go right up to the core of the lesion is sometimes difficult. And that's what was famous kind of classification of bacterial populations, you see. That there are the mycobacteria can be categorized into 4 depending upon the speed of multiplication. You see, the actively growing tubercle bacilli with spurts of metabolism, bacilli in acid pH, and persisters, you see. And there are different drugs act at different stages. This is not a hard and fast kind of classification, you see, and it is not necessarily that you can always have 4 different populations. This is only a concept, while in fact which has been built around the therapy, you see. And now, of course, there are the reasons are different, perhaps genetic difference and so on. We will not go into those questions at present. This is another important issue, that should treatment of tuberculosis be extended if sputum is positive at an end of intensive phase? The general answer is no, because they say if the patient has not responded even at 2 months of intensive therapy, then you don't have to, then there must be some underlying factor, you see. What is important is to review whether patient is taking treatment or not, supervision, additional sputum monitoring, and if possible DST, drug sensitivity test. So that's what is done. And otherwise, of course, what they say, if there is a suspicion, then do not delay the start of second line treatment. Send for DST and resort to the kind of second line schedule, you see, which we just discussed, that there are 2 months of 5 drugs, 1 month of 4 drugs, and then 5 months of 3 drugs, you see. Extra-pulmonary tuberculosis is one important issue which is now increasing in frequency as well, and difficult to diagnose, you see. And we discussed last time also that there are sputum and other smears are often negative here. Because, for example, liver tuberculosis, the lymph node tuberculosis, sometimes you can find acid-fast bacilli in the needle aspiration or other thing, but most of the time it is not as easy or as common as you find in sputum. You see. Similarly, in pleural fluid, ascitic fluid, pericardial fluid, you don't really find tubercle bacilli that easy. So it is difficult to diagnose and start the treatment. Follow-up is also difficult, you see. In pulmonary tuberculosis, it is easy. relatively do sputum examination. Here you can't do biopsy or FNAC every time the patient comes. Patients object to it. So monitoring is also difficult because symptoms do not respond, like backache, you see, common in spinal tuberculosis. Patient may have given full treatment, cured of tuberculosis, but still backache may persist, you see. So that kind of symptoms relief is dubious, you see. Endpoint is also kind of difficult, when to stop treatment. So you just have to go according to the protocol, that you are stopping at 9 months or 1 year, you see. Recurrence is also difficult to find, relapse is also difficult. So all these things are relatively difficult to uh, to talk about in extra-pulmonary tuberculosis. So the standard guidelines are followed, and that's what we have to do. So most of the time the diagnosis, clinical or radiological, laboratory parameters and TB markers are done most of the time. Invasive procedures are required initially, but you cannot go on repeating every time histopathological or therapeutic trial cannot be used as a diagnostic, should not be used as a diagnostic test. So how to manage extrapulmonary tuberculosis is most of the time it is site dependent, and we discuss these uh, kind of classification of diagnosis, that there are different definitive when there is mycobacterial demonstration, probable criteria and possible. So treatment is both site dependent and severity dependent, you see. Because, for example, the patient may be pericardial tuberculosis, may be suffering from tubercular meningitis, you see, or sometimes spinal tuberculosis. So we consider these as more serious forms of tuberculosis. Similarly, miliary tuberculosis, patient may have kind of severe kind tubercular septicemia-like picture, you see. Most extrapulmonary tuberculosis is treated similarly as pulmonary tuberculosis. That is the general principle. Longer treatments for TB meningitis and bone or joint tuberculosis. That's the only two forms of extrapulmonary tuberculosis where treatment may be longer than 6 months. Although there are always debates between the site specialist and the tuberculosis specialist or pulmonologist. We always insist that it should be for 6 months, but uh, the surgeons many times, or even the general physicians, the medical people, they sometimes want prolongation or longer therapies. Why the principles of extrapulmonary treatment is that EPT is mostly possibasal. The difficulties are there in establishing diagnosis, monitoring, and completion, you see. But otherwise, they're possibasal. So there is no idea of, in fact, continuing or giving longer chemotherapies. There is hardly any form of tuberculosis is which carries a higher bacillary load than the pulmonary tuberculosis. A cavity in the lung is likely to contain several billions of organisms, but it is not so in case of spinal tuberculosis, in case of hepatic or cardiac or other forms. The severity is because of the underlying organ dysfunction, see. But anyway, so most forms of extrapulmonary treated, except CNS and spinal tuberculosis, they are treated as pulmonary, which means a short course chemotherapy for 6 months. And steroids are sometimes given for pericardial and CNS tuberculosis. Surgery is required whenever indicated. It may help in early recovery. We'll come to this point very soon, you see. And even persistence or relapse of symptom is not an indication for prolongation or reinstitution of therapy. Because symptom persistence can be there, you see. I talked earlier about backache, you see. Even abdominal ache for abdominal tuberculosis, sometimes it continues even if after treatment is completion. So a lot of symptoms may continue. Backache in particular or other bones, pains here and there, they would continue, some weakness, etc. But that does not mean it is active tuberculosis. So these are the, of course, evidence-based guidelines which were kind of formulated several years ago by American Thoracic Society, and they stand true till date, where you can see that there is A1 or A2 evidence for all forms of tuberculosis, lymph nodes, bones and joints. Bones and joints is one thing where it can sometimes give for 9 months. Pleural disease 6 months, pericarditis 6 months. CNS tuberculosis is the only form when you need to give for 9 to 12 months. Otherwise, for all genitourinary, peritoneal and other forms of tuberculosis, the treatment, there is evidence A1 or A2, you see, evidence is there. Corticosteroids very frequently misused in treatment of tuberculosis, because even a patient is somewhat, they say, if not responding, they say give steroid. But generally they say steroids are of no help in lymph node, bone and joint and pleural disease. The only two indications are pericarditis and CNS tuberculosis, you see, where it is given for shorter period, generally for 8 to 10 weeks or so, low dose relatively. So this is just a repetition that no EPT is associated with a higher mycobacterial load than the cavitary form of tuberculosis. That I think is very important finding, you see. And even if there is a cavity in the liver or elsewhere, it is generally not that kind of infected or heavy mycobacterial load than the lung cavities. There are, of course, serious concerns about diagnosis, monitoring, and follow-up. We just discussed. So what is the advice is that for the same treatment as pulmonary, and here they say the error on the side of overdoing, that if there is a suspicion of tuberculosis, then treat it, you see. That's what they say. The threshold for diagnosis of tuberculosis should be relatively low. See that if there is a strong clinical suspicion, then better to treat than to wait, you see. And when it is a life-threatening location like CNS or cardiac, then aggressive approach may be required. So we have already talked about that. Can steroids help early resolution? Only two conditions, I said, tubercular meningitis and tubercular pericarditis. Other use of steroids in tuberculosis, one is, of course, Addison's disease, because there is a definite deficiency of steroids. Tuberculosis, because it is a tubercular disease. Acute hypersensitivity reaction sometimes to anti-tubercular treatment. And then there is a severe unresolving immune reconstitution syndrome, you see, sometimes. It also may not need treatment with steroids. Sometimes, yes. Do anti-tubercular drugs have interaction with other drugs? Yes, of course, some have, especially gastrointestinal intolerance can be there with the multiple drugs, because but most important is the rifamycin, because rifamycin induces the pathways, common pathways of metabolism, and accelerates, you see. So their concentrations are reduced, especially with the reference to some anti-infectives like macrolides, antifungals and hormones, you see. That's why people, in fact, it is commonly said that earlier, you see, nowadays, of course, the contraceptives are not used commonly, that if patient is taking kind of anti-tubercular treatment, rifamycin, then there are incidences when pregnancy had occurred, you see, and it was kind of attributed to the use. Similarly, cardiovascular agent, digoxin, again, the anticoagulants in particular, you see, they were same problem, that if you give patient is a IHD on anticoagulants and you give rifamycin for tuberculosis, and then there is if you don't don't kind of increase the dose, you see, you may face problems. What about pregnancy? By and large, same treatment, but some caution is required. Streptomycin is ototoxic to the fetus. It is not used nowadays most of the time. Isoniazid, ethambutol, and rifamycin are safe may cross the placental barrier, and there is some fear of toxicity to the fetus and to the newborn. But generally they say, in fact, it may be even good. You see, especially for the newborn who had contact with the infected mother. So it is, but anyway, it is not a, you have to treat if you find it. So, but there is no harm, you see. Except sometimes parazinamide can cause nausea, vomiting, loss of appetite. That can happen with any drug intolerance. So, and that is increased during pregnancy, you see. So one has to be careful, but that is not a real toxicity, you see. So intolerance and sometimes increased hepatotoxicity because the uh, pregnancy causes some stress on the liver, and these drugs can also uh, cause stress on the liver. Breastfeeding should continue on ATT, and treatment, of course, chemoprophylaxis for the babies of mothers with active tuberculosis is required. Just few conditions I'll talk that patients with liver disease, you have to see whether the patient had chronic liver disease or no, and whether there is any drug toxicity or no. So many times the history, of course, and hepatitis virus carriers, past history of hepatitis or excessive alcohol use, these are inquired into. Otherwise, the tuberculosis regimens are the same in all these patients, but the hepatotoxic reaction may be more common in these groups. You see, you should do LFT before starting treatment, although routinely it is not done. But if there are special issues, especially these conditions, then you have to do it. There are many recommended regimens. Standard regimens, of course, is the same, but once there is a hepatotoxicity, then um, you can use the either, even if these are hepatotoxic like rifampicin and INH, you have to use, but these are mild. So I'll come to this point. You see that what to use. You see, these are the hepatotoxic drugs which are known. For example, they are isoniazid and rifampicin and pyrazinamide. These are three important drugs. The second line drugs, of course, ethionamide and minoxidil acid also have. By and large, ethambutol and streptomycin are non-hepatotoxic. See, I think that is one important thing, but rarely hepatotoxic reactions can occur even with these drugs. You see. What about renal insufficiency? INH, rifampicin, and pyrazinamide were safe and used in usual doses. Rifampicin can cause reversible renal failure by immunological reactions like uh, interstitial nephritis, you see. But it is immunological reaction. It is not a cumulative toxicity, you see. It can happen more commonly with intermittent therapy. It is no more used now, and now they are using daily therapy, or when the patient has been irregular in taking daily rifampicin. This becomes irregular or intermittent therapy. And similarly, when the drug has been resumed after an interval, you see. But it is very rare. I think I have seen only 2 or 3 cases in my career, you see, though of almost thousands of cases of tuberculosis treated. So it's not a very common thing. Liver toxicity, of course, is the very common. Ethambutol is cleared by the kidneys, so used with caution. That is the only drug which requires caution and dose reduction. And they have to be adjusted according to renal function, especially for patients with chronic renal disease. You see. If possible, do therapeutic drug monitoring, pyridoxine should be given, and avoid streptomycin or use in a kind of adjusted doses. The other important is TB and HIV co-infection, and both these impair immune response. There is progressive depletion and dysfunction of CD4 lymphocytes, impaired macrophage function, and invasion of inflamed bronchial valves. You see, the breeding sites, the bronchi become the breeding sites. So these are some of the mechanisms by which co-infection can occur. can occur. Fortunately, this problem has been relatively less in this country, and it is even getting reduced now, you see. But this was the one factor which made tuberculosis as the center of concern all over the world, you see, because otherwise Europe and America, they have almost forgotten about tuberculosis. And it was only during the 90s or 2000, early 2000, that there was a resurgence of tuberculosis. And then they start saying that is a U-shaped curve, you see, which has happened. So, and everybody woke up and billions of dollars were invested in tuberculosis research afterwards, because it was a major concern in the Western country. The treatment principles are that both ATT and ART, ART is antiretroviral therapy, should be given. Normally HART, the highly active antiretroviral therapy, where you use at least 3 drugs from antiviral drug groups, or combined ATT and ARP, sorry, is more toxic, you see. I think that obviously because multiple drugs, here patient is taking almost 8 to 10 drugs, you see, and all of them are toxic. So many issues are there, but it is difficult to go at this stage into those issues. But that is what is the common recommendation, that if the CD4 cell count is less than 200, then start anti-tubercular therapy and start antiretroviral therapy as soon as TB therapy is tolerated. I think the basic principle is that you should treat tuberculosis before you really hit HIV infection. But if the count is very low, the CD4 count is low, then start the antiretroviral therapy as soon as TB therapy can be tolerated. So introduce as early as possible. If count is even less than that or 100, then you might start both the drugs together, you see. But otherwise, treat TB first and then introduce the antiretroviral therapy soon. Because the adverse reactions in HIV infected are more frequent, they are related to level of immune activation and immune suppression. Thiacetazine, of course, is not used, so it used to cause a lot of problems, you see, and exfoliative dermatitis. We have seen very severe exfoliative dermatitis with thiacetazine. It's not used anymore. In HIV patients in particular, it was highly toxic. ATT-induced hepatitis is also 4 times higher, you see, than in seronegative patients. Paradoxical reaction, you know what is it? Paradoxical is the temporary worsening of the clinical condition. New radiological manifestations after initiation of ATT and not due to treatment failure or a second process. So that happens quite commonly, and mostly it happens with the lymph node tuberculosis or pleural effusion. So the lymph node getting enlarged, new lymph nodes appearing, that is common. So many mechanisms have been put forward, that there is ongoing inflammation, fibrosis, or immune reconstitution, or release of toxins and so on, but there is no known cause exactly. But certainly it is a heightened granulomatous response, you see. And this is not that uncommon. It's common in HIV patients, but even in other category of patients, this may happen. And many times it is not treated with any specific drug, just give anti-inflammatory treatment. Sometimes corticosteroids may be required for short period. But there is no need of prolongation of ATT or the administration of second line drugs. Now the issue is of drug-resistant tuberculosis, that or poor clinical response in a patient. It could be treatment failure, extensive disease, or associated problems or complications. I think that is, there are many causes of poor, people generally tend to immediately blame resistance, see, drug resistance, whenever you the poor response is there, you see. But it could be many other causes, of course. So drug resistance is only one of the many causes of treatment failure. I think that is an important factor which one should remember. And drug resistance, of course, is a big problem. It is the temporary or permanent capacity of the organism and their progeny to remain viable or to multiply in the presence of a concentration of the drug that would normally destroy or inhibit the growth of other cells. That is the standard definition of drug resistance. And of course, presumptive drug resistance has been defined in the program condition, but I think when you cannot find the laboratory evidence of drug resistance. And I talked about earlier that it could be mono-resistance to the one of the first-line drugs. Many times it is INH, or sometimes sometimes to rifampicin or other drugs. Poly-resistance is more than one first-line anti-TB drug. If the drugs are INH and rifampicin, then it becomes the multi-drug resistance. I think that is because these are the most two effective. Otherwise, if it is INH and ethambutol for that matter, you see, then it is poly-drug resistance. Multi-drug resistance, we have all said, and rifampicin resistance is resistance to rifampicin. Normally, it is presumed that if there is a resistance to rifampicin, there should be resistance to INH. And extensive drug resistance has come into the definition. Earlier, it was total drug resistance, you see, when it was first. But now they say total drug resistance is not a good kind of definition. So it is extensive when you are resistant to fluoroquinolone, one of the fluoroquinolone, and a second-line injectable drug, you see. From a quality assured laboratory, I think that because such reports were being given by many laboratories in Mumbai particular, where it was first found. You see. So the problems with the treatment of MD are the same. When to initiate treatment, what drugs to use, how long to use, how to monitor, etc., etc. And many times isoniazid resistance is found, single drug, and then if high resistance is there, liquid culture, then you omit INH, you see, and give other drugs. If low level resistance is detected, then add high dose INH, because high dose INH is also an effective kind of strategy for treatment of INH resistance. So I think we'll stop. So the drug-resistant tuberculosis, I showed you this chart. These are, of course, the standard first cases. These are the drug-resistant. If there is rifampicin resistance plus INH resistance, or it is unknown, then you give 6 to 9 months of kanamycin, levofloxacin, ethionamide, cycloserine, and all the 3 first-line drugs. You see there. So these are multiple drugs, and normally these patients are best treated in the program condition, you see, the NTEP, because otherwise the drugs are either not available and very costly. Patient will not take these drugs, you see. 3 plus 4, 5, 6, 7 drugs in the initial phase, and these include injectable kanamycin. And then, of course, you have to continue 1, 2, 3, 4, 5 drugs in the continuation phase for 18 months. You see, that I think is again a long period. So these patients are best treated in the NTEP programs. And MDR-TB again. Same intensive phase, but modified treatment based on the level of INH resistance, which I already talked, that there is a low level resistance or there is a high level resistance, and then 18 months of continuation treatment. The extensive drug resistance is even more difficult. Even more drugs are to be used, and these patients most of the time they are admitted and given treatment under supervision. And the adverse effects of the second line drugs are almost same, but more gastrointestinal, cutaneous hypersensitivity, hepatitis, giddiness, and ototoxicity, neurological, especially um, with all the other drugs. Nephrotoxicity is more common, aminoglycosin, aminoglycosides, etc. What would context of MDR-TB? Because that was one important issue, that scarcity of available evidence. The clinical evidence is not there, and the regimens that can be used for treatment of contacts have poor safety and tolerability, particularly among adults. I think we'll omit that, you see. What is the role of surgery in tuberculosis? Surgery is especially helpful in localized forms of extra-pulmonary tuberculosis, especially, or even localized forms of pulmonary tuberculosis. For example, lymph nodes, it can be used, and other bone lesions, sometimes abscesses can be drained, sometimes in the abdominal tuberculosis or gastro or the genitourinary tuberculosis, surgery may be required. It can be required for the treatment of disease as well as for treatment of disease sequelae, or some complications have occurred, perforation has occurred. So all the, but one should not, earlier people used to fear surgery in tuberculosis, that it would aggravate. But that fear is not there, you see. On the other hand, if there even a cavity in the lung, which is drug-resistant tuberculosis, it is best removed, you see. If it is a localized disease, many times it is not a localized disease in the lung. Lastly, latent tuberculosis, because latent tuberculosis form the base or cornerstone of NTEP, you see, for elimination. Because without treating the latent infection, you may not be able to prevent the subsequent form of clinical tuberculosis. It is the state of persistent immune response to stimulation by mycobacteria without evidence of clinically manifested active tuberculosis, you see. We have talked last time also about the positive IGRA test or positive tuberculin test. So if you can exclude active disease, the positivity of these tests do not mean the disease, you see. It only indicates infection. And that is what we can routinely say as a latent tuberculosis, because infected people are likely to develop clinically manifested tuberculosis. This is not necessarily true, especially in high prevalence countries. Earlier we used to define latent tuberculosis in low prevalence country and high prevalence country. In America or Europe, people found with the mantis positivity, they are treated, you see. Full treatment is given. They won't give visa to people from this country unless you clarify those issues, you see. But in high prevalence countries, this may mean almost treating 20 to 30 or 40% of people, you see. Okay, systematic testing and treatment of LTBI in people, but so that is the condition when it should be given, that people living with HIV, patients initiate on anti-tumor necrosis factor treatment, patients on immunotherapy for cancers, for immunological diseases and so on, patients renal disease, receiving dialysis, organ or hematological transplantation. So these are the patients who must be treated, even if the mantis is positive and no other evidence of clinical disease is found. Then the adult and child contacts of pulmonary tuberculosis, you see. This somewhat variable. Adults of adult contacts of pulmonary tuberculosis generally not necessarily treated in this country. But children, yes, you see, if it is a newborn, it should be treated. There is also a recommendation that people in crowded facilities or in kind of where they cannot take care of themselves, prisoners, then healthcare workers who are exposed constantly, immigrants from high TB burden countries, um, homeless people, and illicit drug users. You see, these are the patients who need latent tuberculosis treatment. You see. So these are the guidelines for evaluation that persons in close contacts we have already talked about, and highest priority contacts for evaluation are persons with symptoms suggestive of disease, children of less than 5 years, and contacts with known or suspected immunocompromises. I have talked about these. Contacts of patients with MDR or XDR TB should always be treated, you see. And how do you manage these patient treatment? The WHO guidelines for management differ in developing and middle income countries. And they say these are the treatment schedules generally prescribed that ask for any symptom of tuberculosis for individual from the risk group. If they are there, present symptoms, then you evaluate for tuberculosis, you see. But if the symptoms are not present in those groups which I just mentioned, then do these TST or IGRA test. And if it is positive, then you do chest radiography. If you find any abnormality, test again for tuberculosis. If the test is negative, then it is good. You don't have to do anything. But if the chest radiography does not show any abnormality, but the IGRA test is positive or Mantoux test is positive, then treat for latent tuberculosis. And there are multiple regimens for treatment of latent tuberculosis which have been recommended. Some people say INH for 12 months, INH alone, both for HIV negative and positive cases. Then they say rifamycin INH for 2 months. That's all you see. And for HIV positive patients. Some INH plus rifamycin for 3 months or rifamycin for 4 months, you see. These are some of the regimens recommended. There is no standard acceptance like in the we said for category 1 or 2. Here the kind of optional schedules are available. I think the government of India has to come with clear guidelines in due course of time, you see, and they're still working on it. What schedule can be recommended in this country? The WHO recommends 6 months or 9 months of isoniazid daily. Earlier it was 12 months. Now they say perhaps 6 to 9 months. 3-month rifapentin plus isoniazid weekly. 3 or 4 months isoniazid plus rifamycin daily. So etc. I think multiple schedules are available, but we don't have any firm recommendation. So just now I think that the multiple emerging therapies like pharmacologically new targets for latent tuberculosis, newer drugs are being worked out. Non-pharmacological therapy has also been recommended, immunotherapy, drug modulation therapy, that you see you give kind of immunoboosters which can be helpful, but and prevention of tuberculosis. These are, but none of these things has yet kind of standardized other pharmacological interventions are also being done with drugs, slow release polymer implants there that you just implant, which goes on releasing drugs for a month or so. These are just kind of research issues, you see. Liposomal encapsulations of drugs, just to prolong the release of the drug from the, so that you don't have to get it daily, etc. And other supplements like vitamins, etc. may also be used. So basically, it is the early aggressive treatment which helps as a standard therapy, and the preventive strategies are important. We have discussed some. The other on the community setting, contact is to be avoided. Hygienic measures, food disposal is important issues. Airborne infection control in the wards, especially in the MDR TB wards, and BCG vaccination, of course, It's always given to the newborn, but in adults, I think its role is yet to be found out. You see. So in summary, I think we have already discussed all these issues that insist on microbiological diagnosis for pulmonary and at least on histocytological evidence for extrapulmonary tuberculosis. Use standardized drug regimens and other guidelines. Be patient. Do not add drugs for persistent or recurrence of symptoms, especially for both for pulmonary and extrapulmonary tuberculosis. Treatment for tuberculosis in presence of other diseases requires careful assessment. Drug resistance should be proved microbiological from an accredited lab. Treatment for MD or TB should be given in designed in designated centers, and most importantly is ensure compliance of therapy. Should I ask some questions? There are two questions from the online. So, what is the maximum duration of treatment of TB? Well, I think answer we have already discussed that normally it is for the fresh case it is 6 months, and relapse or treatment kind of retreatment cases it is 8 months or 9 months, and extrapulmonary tuberculosis most of the time 6 months, but meningeal tuberculosis and some bone and joint tuberculosis 9 to 12 months. You see. Drug resistant cases, of course, it is 2 years normally. You see, it is 2 years, and we do not know exact for the extensive treatment, but it is again 2 to 2.5 years or so. What are the newer modalities for diagnosis and treatment of tuberculosis? I think modalities we have already discussed last time, that one is of course genetic. You see, that is the most important, because sometimes it is difficult to find the thief mycobacteria. So if you can find the footprints or the products of mycobacteria, even that is a good enough. And DNA actually is a living component, isn't it? DNA is a living thing. So presence of DNA is the presence of MTB. Theoretically we can say that, you see, after all, that it is only that it is a small kind of miniature form. You see, people, you must have seen all these movies that on dinosaurs, you see, that from DNA found in the mosquitoes, that they create the whole world of dinosaurs. So theoretically, yeah, I mean, it is a fiction movie, of course, but uh, as such, the DNA is a living thing. On the other hand, the other tests, like the molecular tests, sometimes what we call as, they do not indicate the living organisms. You see. So, but many times you have to rely on those methods in the absence of mycobacteria or its DNA. So, and you then rely on histological, cytological criteria or biomarkers, you see, because biomarkers are also indicative in that sense indirectly of the presence of disease. And in very kind of situations, sometimes when there is it is very difficult to find the diagnosis, and then you use your own judgment. The clinical criteria always the doctor uses, but those should be used only in kind of in controlled conditions. You see that you are watching patient is serious, admitted, and you are trying for, but so you should have some reason there, you see. And treatment of tuberculosis remains the same. The newer drugs I have not discussed as yet. You see, the newer attempt is to shorten the therapy to 4 months, and drugs like moxifloxacin, bedaquiline, and pretonomid, they are now available and used. You see, most of the time they're reserved drugs and not routinely used, because we do not want to lose kind of their sensitivity or their use in the patients. So we're sure that in due course of time will find their use. You see. A few questions for you people. We've already discussed these details. What treatment do you prescribe for an untreated new patient? D, 2 months of 4 drugs and 4 months of 3 drugs. I think that's 24-year-old young girl with lymph nodes in neck, granulomatous inflammation of high aspiration cytology. B. Yes, the basically important is that you don't have to give extra duration or extra drugs. It is quite likely that even after 6 months, some lymph nodes may persist. And it is also said that new lymph nodes may appear. You see, it can happen. Lymph nodes are notorious for their kind of persistence and sometimes. So some size, because after all, it is not only the granulomatous lesion that is there in the lymph node. There is a lot of other fibrous tissue, reticular tissue, and so on. So physical enlargement can persist in spite of the. After all, what do anti-tubercular drugs do? They only kill the organism. They do not repair, otherwise heal the other things in the body. You see. For example, they are not antifibrotics. So sometimes you have to resort to other means, surgical means, or sometimes there can be alternate diagnosis. For lymph nodes in particular, there can be many times it can be atypical mycobacteria or the mycobacteria other than tuberculosis, the moths. 50-year-old shopkeeper develops loss of appetite, nausea, jaundice for 2 weeks after ATT. So what do you suspected ATT-induced hepatitis? Which strategy will you employ? Assess for chronic liver disease, hepatitis virus carrier state. B. A. Anyone else? Hmm? Problem here is the A, that assess for chronic liver disease, hepatitis virus carrier, and other things. And after you know the state of the liver, you see, this may take sometimes several days, you see. So you are not giving any treatment. And why stop all the drugs? So B is perhaps more like that. Continue ethambutol because it is a non-hepatotoxic. Stop RHZ, wait for LFT recovery and add RH because pyrazinamide is not to be added. There is some debate on these things. You see that some people say you can add both the drugs together and pyrazinamide can also be given. That also depends how severe is the disease. If tuberculosis is very severe, you might have to give more drugs. Otherwise, best is uh, this policy.
But they gave streptomycin and levofloxacin also. We usually give.
Other schedules also that depends on the severity. That's why I said that uh, you can add, but you don't have to add necessarily. If it is only a question of, for example, lymph node tuberculosis, small lung tuberculosis, you you are only waiting for 10-15 days. You see.
If the disease is not severe, then we can go with only ethambutol if there is ATT-induced hepatitis.
Yes,
Disease is not severe.
and recovery occurs, then you add both the drugs. 64-year-old diabetic, serum creatinine 6.5, cough and fever. Chest X-ray shows low lobe infiltrates. Sputum was positive. B. That I think we have already discussed. Okay. Anybody else?
But so we get modified renal dose modification of ethambutol. We want to stop it.
Yes.
We give like half the.
There are other options. We have to select from these four, you see. But you withhold. It is not necessarily that you don't have to give. Again, it depends upon the severity of disease as well. I think all the time you should also, if the disease is severe and you need to treat it with because otherwise ethambutol maybe if it is a less severe form of tuberculosis, you can just take out leaf. So we have already discussed the reason. Ethambutol is the only drug cleared by the kidney, so use with caution. Rifampicin is continued because it is a hypersensitivity reaction form of tuberculosis. There are 2 or 3 cases. 50-year-old male weighing 100 kg develops pulmonary tuberculosis and loss of weight. Current weight is 95. What is the treatment schedule here? What? B or D? C. Okay. Yes, I answer is C because hey, that is the recommended dosage schedule. That maximum dose of INH is 4 of rifampicin is 600 milligram, and paracetamol is 2 grams. So the exceeding maximum doses is not helpful because there is a plateau effect, you see. So whatever effect is to be achieved, it can be achieved with that. And then the chance of toxicity will be more. Similarly, there will be an increased chance of interaction or inactivation. So here is a patient with small pleural effusion, relatively well, treatment with rifampicin, INH, paracetamol. Severe rash, all drugs are withdrawn. The rash disappears. And one drug is to be introduced every 3 days. A. INH, rifampicin, ethambutol. Any different? So reintroduction, you should balance the indication with drug toxicity because drug reaction is a sensitivity reaction, so it can happen again. And how do you determine the sequence? They say it is a likelihood of toxicity because that is the only way to know that which drug is more likely to cause. And careful monitoring is required. And this is what is the likelihood you see. The least likely with INH, rifampicin, paracetamol, ethambutol, and streptomycin. Okay. Thiacetazone, of course, is not used. And they also said now, again, if the disease is possibly, you can just rely on the 3 drugs. You see. Okay. Any question?
Okay. Patient hepatitis B and the LFT marker LGOT, LGPT are the range. So in some patient, whether we should go with the usual regimen or we should start with the dose modification. The patient is already on the baseline LFT guideline.
Baseline LFT is abnormal.
Thanks for TB. And now we have to start the ATP for this patient.
Yeah, again, it would depend upon one, of course, is the how strong and how severe is the indication. If really it is very strong indication, then it is better to start with the safer drugs like ethambutol, streptomycin, and levofloxacin, and then assess for all liver disease. You see, every investigation, including the carrier, besides the liver function test, the viral load and other things, and ultrasound, and if need be, even sometimes FNAC or biopsy may be done. You see, because it is if you find it is a chronic active hepatitis, you see, then you have to add corticosteroid as well. You see. Okay, and pyrazinamide is generally avoided in all situations in this. The other drugs like rifampicin and INH may be given. That also depends upon the patient. So you have to balance between the liver disease and the pulmonary disease most of the time. If it is cirrhosis, chronic disease, then pyrazinamide is avoided and other drugs can be given under caution. You have to be kind of monitoring, you see, regular monitoring for liver functions and more rigorous monitoring, you see. So There is the worst condition is the chronic active hepatitis, you see, or any active hepatitis, because that may precipitate liver failure and cause problems. Okay, thank you.